Welcome back. The treatment of Alzheimer's continues to improve. As new therapies are approved by the FDA, doctors have more options for their patients, leading to better and more patient-centered care. Ideally, a patient who has a concern about their cognition will see their primary care physician, have the confidence to raise the concern, be screened for potential impairment, and if appropriate, be referred to a physician with the skill, experience, and infrastructure to consider this patient for new Alzheimer's therapy. So what steps are leading clinicians and health systems taking to ensure that each Alzheimer's patient who qualifies gets the right drug and in time to make a difference? Kicking off that conversation is Deborah Lappin, Senior Strategic Counsel to Us Against Alzheimer's.
Hello. Welcome to day 2 of the Us Against Alzheimer's Summit and our first panel, where we will look at how we will meet the demand for new treatments to Alzheimer's therapies. We have an extraordinary panel with us today, people who many of you know well. Jeff Cummings, Joy Chambers-Grundy Professor of Medicine and Brain Science, co-director of the Quirk Brain Health Biomarker Laboratory, director of the Chambers-Grundy Center for Transformational Neuroscience, all at the University of Las Vegas. Darren Gettleman, director of cognitive disorders at Advocate Medical Group, neuroscience medical research director and senior medical director at the Memory Center, Advocate Healthcare. And Dr. Ron Peterson, Cora Canao Professor of Alzheimer's Research, Director of the Mayo Alzheimer's Disease Research Center at the Mayo Clinic College of Medicine. Thank you for being with us. Your bios and your full disclosures, of course, are on our website. Let us turn now to where we were, what our introduction said and how we could begin. Dr. Cummings, I want to start with you. You have been in clinical practice for many years, UCLA, Cleveland Clinic. You have probably been involved in almost every one of the innovative biological drugs, monoclonal antibodies. And you have been a thought leader in how we will bring these drugs into clinical practice. In a few words, describe the profound change in today's environment for both clinicians and patients, and what are medical centers doing today that's different from what they did 2 years ago?
Thank you, Deborah. It's great to be on this panel. Really a great question. We've all used the term, this is a new era, and I'm personally so excited about it. Before this time, as you know, we had only symptomatic therapies. We were happy to have them, but they did not change the trajectory of Alzheimer's disease. Now we have disease-modifying therapies. We have great evidence that they slow the disease, and therefore they keep the patient functioning at a higher level for a longer period of time. And that's our goal, is to preserve the human mind and human dignity for the longest that we can. But these drugs are complicated. They impose new demands on clinicians, and I'm sure we'll hear more about that. And correspondingly, they impose new demands on healthcare systems. Resources have to be there, the imaging resources, the infusion resources. These are all new demands that we have not experienced before. So it's a new era, and it's also an era of profound change.
And thank you for starting us off at the systems level. I want to stay there. And as we progress in the next 45 minutes together, go down and ultimately end up in the clinic with that patient-clinician interface. But staying at the systems level, Dr. Peterson, you've been waiting for this moment for decades, I think. And you lead one of the largest, most impressive Alzheimer's programs in the world. So what is the Mayo Clinic doing to prepare for the demand that I know is at your doorstep?
Well, thanks, Deborah. I appreciate being invited to participate in the panel with Jeff and Darren. Yes, we at Mayo have actually just the beginning of this month initiated our Alzheimer's disease treatment clinic. And this is specifically designed to deal with these monoclonal antibodies in the treatment of Alzheimer's disease. So a lot of infrastructure work has gone into preparing for this day. And I must give credit to my colleagues, Dr. Jonathan Graff Radford and Vijay Ramanan, because they're the two people in our department who have led the effort. But essentially, the way we're going to approach it, initially, we're going to be quite conservative because we want to do it right if we can. We're setting up a clinic where we will be evaluating perhaps 3 to 5 individuals per week. We'll start at the beginning of the week with individuals who likely may be candidates for these therapies. We will see them clinically. We'll do neuropsychological testing, clinical exam. We'll do an MRI scan to make sure that they don't have any excluding characteristics for these treatments. If they have an acceptable MR, we will do a PET or a CSF, the documentation that they have the amyloid protein. If they qualify there, we will then do apolipoprotein E4 testing because we need to counsel them on risk factors. And if all of these pieces fall into place, then we have a consensus conference at the end of the week where we discuss the appropriateness and eligibility of each patient. And if we feel they are appropriate, we will offer them this therapy. We will conduct it here at Mayo, at least in Minnesota initially. We're going to be seeing people from our geographic region because we want them to be able to contact us, come back if there are problems. If people qualify, live outside the region, we'll refer them to other clinicians. But we're going to do this very carefully, cautiously. We've got our entire team teed up for this, and we're hopeful that we're going to be able to help some people.
And I don't know how others are hearing this, but I stopped at 3 to 5 a week. Those fortunate 3 to 5 people who get through that door. Dr. Gettleman, how will it work at your health system? I'm going to start there because we've heard from Dr. Peterson. Can you tell us how Aurora Health is adopting? Advocate.
Yes. And thank you very much for having me on this panel as well. I'm really honored to be in the presence of Ron and Jeff. So at Advocate Aurora, I think we're taking a very similar approach to what Drs. Peterson and Cummings have described, a conservative approach at first. No one wants things to run badly on patients. No one wants to include so many patients that are not appropriate and then run into trouble with those patients and the side effects. We are considering something similar to Dr. Peterson in that we'll have a type of Alzheimer's quality initiative panel in which we can review patients and discuss them, what their imaging shows, what their including excluding criteria are, and so on. Dr. Peterson mentioned genetic testing, in this case, not to diagnose Alzheimer's, but to diagnose the risk of having a side effect of these medications. We will really consider that required and very important for these patients. I think like many health systems, we're probably going to struggle with the numbers of physicians who are qualified to give these medications in our system. Throughout the US, there are, I think, less than 100 fellowship spots each year for geriatricians, geriatric psychiatrists, behavioral neurologists. And, probably if you added them all up, it's probably one of those physicians per 30,000 or so patients. So there's, a lot of work to be done, a lot more people to be trained. We're also going to be training our primary care doctors, our emergency room physicians, our stroke physicians, because patients could show up with side effects if they come into their primary doctor with a headache. Is it a headache or is it a headache from the medication? They have to think about that. Our ER doctors, our stroke doctors have to know not to use those clot-busting drugs on patients on these medications. So that's our approach, but I think very careful, as Dr. Peterson prescribed, and thoughtful and build consensus among the doctors in our system.
You have any?
Add one thing to this. This is so exciting to me because I think we're learning also how to introduce new medicines to our patients and to healthcare systems. I think we're all hoping that monoclonals are not, the last step. They're the first step. And we're going to have a lot more new medications. They're going to have, each one of them is going to have their own effect and their own side effect profile. And we have to have systems that can introduce these new medications quickly to our patients. And I think that's part of the process that we're learning about now. How do we change from what we've done for so long to introducing exciting new therapies?
Yes, and Dr. Peterson, were you going to say something? I mean, staying at the systems level, what if you were going to say, and let's go ahead with that first, and then I have a question for you.
No, I think Jeff is exactly right. I mean, we have taken the approach that these individuals may enter our system from multiple different points. And so we've highlighted the emergency room physicians, the neurologists who will be on call 24/7 for general neurologic issues. If one of these patients calls, what do we do with it? So it's really taken a broad set of preparatory actions, and hopefully we're all set.
Well, I want to put a pin in that and come back to your new relationship with a primary care doctor and how that is going to work. But let's stay at the systems level. What are the biggest barriers that you see, Dr. Peterson, with what you've described as the immediate new state, the 3 to 5 individuals a week, going to the panel on Friday? What are the biggest barriers that have to be identified and then remediated?
I think it's going to be essential that we fit people into the treatment protocols very carefully. That is, if you talk about all of Alzheimer's disease, the breadth of Alzheimer's disease through all degrees of severity, many people will not be eligible for these drugs. So I think we have to educate our colleagues, our clinicians, our primary care physicians, and the general public that there's a relatively narrow swath of individuals with Alzheimer's disease who may very well qualify. Since we don't know how these drugs might be effective outside of those barriers, whether they'll be safe outside of the limits of the clinical trials, I think we need to be cautious at first. So I think education in terms of who might be the most appropriate people to benefit from these therapies.
So I'm going to stay with you for a moment, Dr. Peterson. If I'm not mistaken, you are the individual who is credited with our understanding of what mild cognitive impairment really is. Maybe you wouldn't say that, but I think many might.
Nor would my wife. So that's you get different opinions from different people about your own credibility. So I hear you.
How will primary care doctors get the level of understanding of mild cognitive impairment that you have? Will they know it when they see it? What do the primary care doctors need in order to get people to your doors in time?
Yes, I mean, I think mild cognitive impairment is an essential part of this discussion because if you look at the clinical trials that have documented the efficacy of these drugs, the majority of people in these clinical trials have the clinical diagnosis of mild cognitive impairment. So I think it's important to sort of understand what that is. Now, most of us know it's sort of that in-between condition. It's more than the cognitive changes of aging, but it's short of dementia. So these are often individuals who are memory impaired beyond what they used to be, maybe beyond what they ought to be, but otherwise they're functioning pretty well. They look pretty normal to the casual observer, yet these people are at the beginning of the symptomatic stages could be at the symptomatic stages of Alzheimer's disease. Mild cognitive impairment is just a syndrome. So we need then to verify that the cause of this syndrome is underlying Alzheimer's disease, and that's where the biomarkers come into play. But Deborah, you mentioned the primary care environment. I think, and I may be misreading the tea leaves here, I think primary care physicians are coming to recognize these more subtle degrees of cognitive impairment and are recognizing that people who come into their practices complaining of a memory impairment rather than saying, yeah, I got it too, are saying, what do you mean by that? And are able to drill down. So I think that's the first step, to do a little bit of a clinical evaluation of individuals with these cognitive complaints. And if they feel that maybe there's something here beyond aging, then refer them on to the specialist to try to sort it out. Is it mild cognitive impairment? So I think the recognition, I mean, mild cognitive impairment, I don't want to go on too long here, I mean, is a reimbursable entity. So it does have ICD codes. It is recognized in DSM-5 as mild neurocognitive disorder. So it does have an established place in our general armamentarium as clinicians. And I think it's going to become increasingly important.
Dr. Gettleman, that was very hopeful. Do you see that playing out in your health system?
Yeah, so I wanted to make a comment a little bit about the previous, and then what Dr. Peterson said. So the other people that I think need to be trained in a sense, governmental agencies, Medicare now, for example, reimburses for certain metrics of disease. If you have your colorectal cancer screening, your blood pressure controlled, the hospital systems get paid to have people up to date on that. Those are very important. They've been shown to make a difference. Unfortunately, Alzheimer's disease and the other dementias, that they make control of every other disease worse. And but yet there are no metrics yet for diagnosis, for treatment, and for following patients. And I think that's going to be necessary to incentivize health systems, incentivize physicians. More people will enter the field, and the whole system will focus on the care and safety of those patients more. So that's one. The second, the other sort of group is the leadership of these health systems. I was speaking to our pharmacy and therapeutics committees the other day, and an oncologist, interestingly enough, raised their hand and said, why should we approve this drug? Is it worthwhile? Doesn't cure Alzheimer's, potentially significant side effects. And I replied, let's think of this, in terms of some of the medications they use, these palliative types of medications. So Alzheimer's is a potentially terminal illness. And, we now have newer palliative treatments. In oncology, is perfectly acceptable for treatments to prolong life a few months, and people, hang their hat on that. They really focus on that. Well, here we now have a treatment that's going to take people back a few months, so that they're a little better than they might have been without the treatments. And so that reprieve really makes the difference for our patients. I think those groups need to be educated as well so that they support these medications. And then, as far as what Dr. Peterson said, yes, I do think that physicians, primary care, are learning more about what's necessary. But too often, I think sometimes patients sit in the primary care clinic, come to us at moderate dementia, and particularly some of the underserved minority populations don't get diagnosed on time. And then by the time they reach us, they may not be eligible for the treatment. So I think, again, pushing that education will be very important.
You just touched on such an important topic for us against Alzheimer's, and that yesterday our summit began with equity in Alzheimer's. And I wonder if any of you could tease out a bit further for us whether there is a serious risk that individuals from different socioeconomic, different access opportunities will be in a holding pen in primary care and not get into a specialist who has the capability of prescribing new monoclonal antibodies.
Maybe I could start off with that, Deborah. One of the things that is a topic of concern right now is the exclusion of obese people from clinical trials. So there are, for example, weight exclusions for clinical trials. Well, obviously, people who have greater weight have a larger volume of distribution for the drug, and they will get lower exposure when these drugs are in private practice, and they're not excluded from trials, or they're not excluded the way they are in trials. So one group of underrepresented individuals that we really have to begin thinking about, because the biology is obvious, is the inclusion of a wider range of weight individuals, particularly because obesity and diabetes are risk factors for Alzheimer's disease, and there's going to be many such individuals. So I think we haven't thought enough about that as we've considered the many types of underrepresented groups for trials.
So now I do want to go back to, you triggered an important line of conversation. and that is, Dr. Peterson, you published a study from Mayo Clinic maybe 3 or 4 months ago that looked at using the clinical trial inclusion and exclusion criteria as the basis for who you may prescribe a new drug, to whom you might prescribe. And you found that a very low percentage, as 8% or something, of the patients that might think that they could go on a drug would in fact meet those inclusion exclusion criteria. As a layperson, that was pretty disappointing news, I felt. So talk to us, are you using clinical trial inclusion exclusion criteria as you decide who is right for a drug? And if so, who might be left out by that approach?
Well, as I indicated earlier, Deborah, we're taking a conservative approach here in rolling out these medications so that, one, we understand them, we learn about them, administer them in a safe fashion. But the study you're referring to is something that we did here in our community. We have a infrastructure study called the Mayo Clinic Study of Aging, which is a random sample of people who live in our community. But we've been studying them for decades, and we have a great deal of biomarker information on them. So we thought we'd use them as a platform to investigate the eligibility of people for these medications. So basically, we started with people in the community who are of the proper age for the medications. We asked how many of them we had made the diagnosis of mild cognitive impairment or mild dementia. We then looked at the subset of those people who had biomarker data evidence, and we came up with a group who were amyloid positive, MCI, mild dementia. Then we took a look at them and said, now, would we treat these people? Do they have exclusionary medical conditions that may make them less likely to participate or participate safely? So, for example, people who are on anticoagulation, we excluded them. If they have diabetes out of control, hypertension out of control, other medical conditions that may make us cautious about treating them in a safe fashion, we ended up with perhaps only 10 to 20% of that population that would be eligible using the inclusion-exclusion criteria of the clinical trial. Now, those figures are not hard and fast, but the point is it wasn't 80, 90%, it was 10 to 20%. And as you said, we published this just recently, and have gotten some letters back saying that, gee, in our population, we kind of did that and came out with roughly the same numbers. So I think on the one hand, it's disappointing that we're not treating a larger segment of the population. On the other hand, if we do this correctly and safely, we may need to follow those guidelines.
Dr. Gettleman, are you applying the same clinical trial inclusion exclusion criteria as you look at individuals who may qualify?
Yes, we are. I thought the work by Dr. Cummings and that entire team was fantastic. Sorry, I'm not part of the group, but seriously, they have experts, internationally in clinical trials, Alzheimer's research, diagnosis, treatment, vascular complications. I think the criteria are rational, but they actually are more conservative than the clinical trial. And I think that's a take-home message, certainly for the physicians in the audience today. Be conservative, be safe. Recruit the right people. They will benefit based on what the clinical trial showed, and you're less likely to run into some serious complications potentially for these medications. So yes, we are absolutely going to be conservative and following those recommendations. The other point, I've spoken with Dr. Cummings before. He made the point that these are not set in stone. We're learning every day about how to dose these medications and the response to them. I think there was a previous recommendation for aducanumab. It's already been modified. And I would expect for lecanemab, probably donanemab eventually, there'll be initial recommendations and then there'll be modifications as the group learns more and we all learn more about these treatments.
So Dr. Cummings, I think Dr. Gettleman referred to appropriate use recommendations, that you have convened quite a group to provide this kind of guidance to clinicians. Could you describe what the appropriate use recommendations are, the process that you've conducted, and how these recommendations are getting into the hands of clinicians who need them?
Yes, thank you, Deborah, and thank you, Darren. That was a great introduction to our group. And Ron is a part of the group, so Ron, thank you for that. We call this a therapeutics working group. When aducanumab was approved and we reviewed the prescribing information, we realized it was not enough to guide clinicians in the way to map the guidance into your practice. So how do you actually schedule the MRIs? How do you actually do the infusions? How long do they take? What is the justification for it? And what are some of the practice nuances? It's important to note that we do not discuss efficacy. So these recommendations are for how to use the drug once someone has decided to use it. And I think that's an important nuance. Group is composed of a group of experts, as Darren suggested, that have deep knowledge of Alzheimer's disease and therapeutics, and are independent of the Alzheimer's Association, independent of any pharmaceutical company, and bring to bear an independent voice in terms of the use of these drugs. So I think the work has been very good. Just to tell you the magnitude of the interest, for example, our lecanemab recommendations, which came out relatively have already been downloaded 31,000 times from the JPAD site. So these are being widely used. They're influential, and I think they're important. I'm really proud of the way they are being used. Donanemab will have its own appropriate use recommendations if it gets approved in December. And we'll have a different leader for that group. I think we need more perspectives and more individuals who are participating in the group.
I just want to push you all a little bit, and believe me, this comes from appreciating that you three gentlemen have every patient's health at heart, and you're the best of the best. But it just, I think, strikes us that these recommendations will exclude a population that may be minoritized and may not have been in the trials because of the very exclusions that will continue now to be perpetuated. So even if we capture real world evidence, are we going to be capturing evidence on that perfect subject versus an African-American male who may be overweight but has managed cardiovascular disease? Can you help us with that? If we end up our conversation today, where should we be in 3 years? Will this change, and what will change it?
So I'll start, but I'm really interested to hear the other ideas about this. We're conservative because it is the trial population in which we know the efficacy and the safety of the drug. And that's the only population in which we know the efficacy and safety. So that's why we're building from that base. We will get some real world evidence because there will be some practice outside, some application outside of the appropriate use recommendations. But what we really need are trials in more diverse populations. And so I see us as in a transition phase from this very limited participation to a more inclusive participation in our trials.
Through clinical trials, I'd like
I can comment on one aspect of what Jeff was saying. Often people from underrepresented groups may not have access to the types of technologies that are required for some of these studies. For example, if you need a PET scan to demonstrate that you have amyloid, you need a lumbar puncture to demonstrate you have amyloid. These may be less available to individuals from underrepresented groups. A major advancement in the field that is happening almost weekly is the development of blood-based biomarkers. So it may be the case that blood-based biomarkers may actually substitute for the PET scan or the lumbar puncture. We're not there yet, but they certainly are leaning in that direction. And if that's the case, we may be able to raise awareness among all populations of the frequencies of these diseases in underrepresented groups that may not have been studied adequately, but it also will entitle them to become eligible for these therapies. So I agree totally with what you're saying, Deborah, and what Jeff said, that people have not been included in many of these studies. But I think that landscape is changing, and hopefully individuals from underrepresented groups will be eligible for these drugs.
I'd like to make a comment as well, Deborah. So I agree with everything Ron and Jeff have said. We were part of the U.S. Pointer trial, which was funded by the Alzheimer's Association. They really made a tremendous effort. I mean, that was like built into the DNA of the trial to recruit people from underserved minority populations, and that was very successful. They had a sort of 25%, I believe, from underserved populations. Unfortunately, the industry-based trials have had a much lower percentage. And I guess, we were speaking at first about education. So we've educated our primary care, our emergency physicians, stroke physicians, leadership, but we have to educate patients too. We'll have to go out into the community, speak at, churches, community centers, so that people understand to bring their loved one in to get the diagnosis, and then I wouldn't say demand, but to ask about these treatments. And the treatments are difficult. They require a lot of commitment. Lecanemab is every other week infusion. So patients and families have to be prepared for that. But I think that's another group to educate about these medications, the importance of early diagnosis, not to fear the diagnosis, not to hide from the diagnosis, but to go out there and get that diagnosis and then get the appropriate treatment.
Thank you for taking us now from the systems level down to how you're communicating with the clinician to patients and their role too in seeking care and demanding care and not being hesitant. These are all important major issues for us against Alzheimer's. But Jeff, I want to go back to you. You and I have talked briefly about what would a patient's Bill of Rights look like? And Voices of Alzheimer's, led by Jim and Jerry Taylor, have started to propose and begin to lay out what a patient's Bill of Rights would look like. And I'm assuming that's not just a white patient's Bill of Rights, it's all patients across our society. What would be in that Bill of Rights in your mind, Jeff? Let me start with you. I'd love to come back around to both of you, Dr. Gettleman and Dr. Peterson. What should patients be doing today to demand the care that they deserve? Oops, Jeff, you're muted.
This was a new idea for me, Deborah, the Patient's Bill of Rights, and I really like it. It seemed like the right thing to me, because we need this alliance between patients who need these drugs, doctors who prescribe them, developers who develop them, payers who pay for them. This is an ecosystem, and it all has to work together in order to get the product that we want, which is a higher functioning patient. And the patient needs to have a voice in that. I just love this idea. So how would this work? Well, I think it's reasonable when medications are approved by the FDA and funded by Medicare, that the patient demands of their healthcare system that this is something that we need. This is something we have a right to because we're in this healthcare system. The nuances I think will be complicated, but this is the time for it. This is the kind of challenge that allows us to come up with new solutions, and I think this is a new solution.
Dr. Peterson?
One aspect of this that I think brings into focus our own behavior, and I'm talking about myself here, but clinicians, investigators in the field, is not to be too paternalistic about these issues. Like, we know the answers, we know what you should or shouldn't do, Mr. or Mrs. Patient. I think we need to listen to our patients and ask them, how much risk are they willing to encounter with regard to these therapies that may have some definite risk factors to them? So I think we have to be cautious not to be. Earlier, I said we're being conservative here. We are being conservative. We think for good reasons. But at the end of the day, I think the needs of the patient come first. And I think we need to entertain the discussions with them, listen to them, and not be too prescriptive about how we use these medications eventually. Initially, yes, but eventually, I think we need to broaden the use frame.
Mhm. We're going to come back to that. Dr. Gettleman, would your,
Yes, yes, go ahead.
well, I just want to stay on this patient's Bill of Rights. What might it have in your health system? Is there a right to see a specialist within 6 months, 4 months?
Well, I think like any health system, as I mentioned, where there are going to be those limitations that the system is working on. I think patients have a right to demand appropriate treatment and in fact, the best treatment possible under a particular circumstance. I don't think they can demand any treatment. You wouldn't use an antibiotic if you knew someone had a viral illness, for example, and these medications are going to have some limitations to them. And as Dr. Peterson said, over time, we're going to learn more and we'll probably loosen those criteria. We had such a patient in our clinical trial. They were coming off of aducanumab, as it were, because that trial's ending. They were really terrified. They look forward to that infusion every single month. And, what would happen to them if they went off of it? We talked with her a little bit about it. But as it turned out, she ended up getting an amyloid PET scan. She was told that there really is just no more amyloid. There's no extra amyloid in your brain. And it was reassuring for her to see that and for her husband to see that. And I think in doing so, it led them to an understanding that they could release that treatment now, not demand it anymore, and then look forward maybe what the next therapy would be. So I think this is really part of the shared decision-making that Ron brought up with our patients. Our jobs as clinicians are to figure out the best ways to communicate, understand patients' fears, try to address their concerns with evidence, but with compassion as well. And I think people want to make the right choices.
Deborah, one of the things that struck me, is many states have the right to try laws. Nevada is one, for example, where patients can request or demand the right to try experimental medications. Well, here we're talking about the right to try approved medications. So it certainly is less dangerous than the existing right to try laws, because this is actually the right to try an approved drug.
But the person who wishes to exercise that right may not meet the stringent, stricter, safer, out of the starting box approach that we're hearing is a well-reasoned approach. So we have maybe a right to assert access versus this really understandable approach to conservatism, so we know how these drugs work. It's quite an ethical challenge, and I love, and I think our audience loves picking your brains and the social covenant that comes from the patient. When the amyloid is gone, is that like, well, the tumor's gone, Dr. Gettleman? And so do we stop the therapy then? And also, what if the patient progresses despite the therapy and they're really past the point where we think the therapy can help? Then do they have also as part of this covenant that they understand they'll go off the drug?
Those are very, very difficult questions. I think Ron and Jeff and I had discussed this in a previous meeting, and the drugs work a little differently. Some of them target plaques, which are picked up on a PET scan, for example, and where you could say, oh, that's definitely gone. Others target other molecular species of amyloid and may not quite focus on the plaque. So it can be difficult to know when it's truly gone, or if the other molecular species are having an effect on neurons, synapses, and so on. So, at this point, one of the trials, the donanemab trial, sort of explicitly looked at whether medication can be stopped and what the consequences are. Lecanemab has not done that. Hopefully other studies in the future will look at what the stopping criteria are on for these medications. And I think that's really one of the hardest questions I don't have an easy answer for that. I think as people progress, as they become moderately impaired, we do have evidence that these medications are probably not going to be beneficial in that population. And, as we've always done with patients with Alzheimer's, we have to connect with the patient and family so they know we're there to support them, not to paternalistically say what they can have and not have, but that we will do our best to treat them throughout the course of their illness, not give up on them, always look for ways to help them live their best life. And but at points we may have to say, this I don't think is an advantageous medication at this point in the disease for you. Let's look at other ways we can support you.
Yeah.
I would just like to add to what Darren was saying, that I mentioned earlier the role of blood-based biomarkers. They may play a role in this stopping of the intravenous infusions. That is, I mean, as Darren mentioned, the donanemab trial did use that and seemed to suggest that once they lowered the amyloid level to baseline, stopped treating, that the situation was fairly stable, at least through the course of the drug trial. Now, that raises the question of, might we be able to treat people, drop their amyloid levels down to baseline, stop treating them, and follow them with a blood test? If the blood test starts creeping up, if it in fact is an index of amyloid burden, we might retreat them. So, but this is all what the field needs to learn about, and that's why doing these initial clinics that will gather these data using the national registries that are out there, I think we'll learn more about these aspects of how to use these drugs.
Yeah, and I would just add, Deborah, that it's very interesting to me that the FDA explicitly says in the prescribing information, these drugs are approved for initiation in early AD, and they leave the duration of treatment open. And the 18-month trial is completely arbitrary, right? This is about, how far we've gone around the sun. It has nothing to do with biology. So the idea that there's something magic about 18 months of exposure, I think is completely unsupported from a biological point of view.
Is real world evidence going to answer some of this? I mean, you say another clinical trial. Is there a way to optimize every 5 patients every week that Dr. Peterson says, likewise that Dr. Gettleman says, and will we learn anything faster that way?
A couple of things. One is registries are really important. We have to capture this information, the real world information. And the other is the trials have open label extensions where everyone is treated. And although there's no placebo, there's an ability to learn or infer some information from those open label extensions.
So we come back, we have the same panel in 2 years. Give me a scorecard that you each, what are the components of it to show that we have moved the ball from where we are today in this discussion to a system that is decidedly better at getting a new therapy to the right patient at the right time to make a difference? What do systems need to do if you were CEO of your health system?
Well, I certainly hope that the drug's efficacy are going to be validated, and the safe use of them, and the boundaries of when we can and cannot use these drugs safely. So we'll have a better idea about that. So we may be able to expand the patient population. I think while many of us are starting in the specialty clinic environment for the use of these drugs, hopefully that will expand. General neurologists, geriatricians will feel comfortable, maybe primary care doctors, may or may not. But I think those possibilities exist. So a couple of years from now, we'll be able to look at that scorecard and see, have we expanded the use of the drugs outside of the specialty clinics? And have we learned more about the appropriate patient populations?
Excellent.
I'll jump in, Deborah. I'll give hope a 10. I think we've really penetrated into an area where we will be able to help patients more over time. So hope gets a 10. I think system preparedness gets a 3 because we have a long way to go. But in 2 years, we'll be at 6 or 7 and we'll be reaching far more patients than we currently are.
Okay, I'm going to hold you to that measure.
I think, Yeah, this is instead of the beginning of the end, this is the beginning of the beginning. And so a lot to learn there. I'll say the other parts of it are we will adapt our electronic systems, I think, to monitor patients better. I think there's hope with AI and other technologies that will have a more robust means of picking up on the side effects on radiologic scans and monitoring those over time. I think hopefully we'll have more biomarkers. You know, now we have a hard time diagnosing multi-pathology. Do we know that the patient just has Alzheimer's and not also Lewy pathology or other pathology? And so we'll be able to target it, personalized medicine in a way that we select the patients appropriate for this treatment. Earlier diagnosis, as we've mentioned as well. So all of that I hope to see in the next couple of years.
Well, I hope we can join each other again in 2 years and see how we've done. Thank you each, Dr. Peterson, Dr. Gettleman, Dr. Cummings. Thank you for all you do for people with Alzheimer's.
Thank you.
Thank you.